Hi everyone, I'm Belle Spagnoletti, a research fellow in sexual and reproductive health from the Nossal Institute for Global Health at the University of Melbourne and a visiting researcher at Gajah Mada University Centre for Reproductive Health. I'd first like to acknowledge the traditional custodians of the land from which I'm presenting today, the Kaurna people of the Adelaide Plains, and I pay my respects to them and their elders, past and present. And I'd also like to extend a warm thank you to Ignacia and Yulia for giving me the opportunity to contribute to this workshop on ethnographic approaches to research on health inequalities. And thanks to those of you who are taking the time to view my presentation. And please, if you have any further questions, feel free to drop me a line via email. And today I'm sharing with you a framework for understanding women's reproductive experiences and decisions, which I developed for my doctoral research in Indonesia, and I call it the RED, W-R-E-D framework for short. I'd like to walk you through the process I went through in developing it in today's presentation. So first, I want to give you an overview of some of the persistent sexual and reproductive health challenges in Indonesia that disproportionately impact women and girls. 11 years ago, Terry Hull and Henry Mosley handed down a report commissioned by Indonesia's National Population and Family Planning Board about revitalising the National Family Planning Program. And in that report, a number of clear recommendations were detailed for programmatic change to support women's reproductive health and their rights. A decade on from that report, and after half a century of interventions to improve women's reproductive health in Indonesia, there are still a number of persistent challenges. One of the key indicators of women's reproductive health outcomes is the maternal mortality ratio, which in Indonesia remains stubbornly high. It's among the highest in Southeast Asia. Access to reproductive health services, including contraceptives for all women and men of reproductive age, has not been realised, and unsafe abortion remains a problem. But because of the stigma surrounding terminations and sex before marriage, we don't really know the full extent. Every day, 50 women die from cervical cancer in Indonesia, even though it's a preventable disease. So that's 2 women every hour dying because of cervical cancer. And Indonesian women's educational attainment continues to grow, yet during their reproductive years, their involvement in formal employment is constrained. And this then has downstream implications for their health and the well-being of both these women and their families. Now, Indonesia is an archipelago state, and it's extremely diverse in terms of socioeconomic divisions, ethnicity and language, age and geographies. Therefore, approaching these reproductive health challenges with a one-size-fits-all approach is just not going to be effective. So as part of my doctoral research, I set out to develop an analytical framework for understanding the reproductive health context in Indonesia, allowing for targeted and nuanced analysis that could contribute to developing more appropriate responses to reproductive health issues. So I'll just give you a quick rundown of how the RED framework was driven by my data collection from my research in Yogyakarta. So I was in Yogyakarta undertaking ethnographic work for 18 continuous months, and I was seeking to understand women's experiences during the postpartum period. So my participants were mainly middle-class Muslim women, and the focus was on breastfeeding, family planning, and how these women juggled their paid work with their unpaid work, such as parenting. I conducted interviews with 20 women and 5 key community stakeholders, as well as focus group discussions with 7 health professionals from primary health clinic and 7 breastfeeding counsellors. And I also attended breastfeeding information and support sessions, and I undertook extensive analysis of policies that were intersecting with the reproductive health of my participants, including health and labour legislation. And so I just want to share the process of how I went about collecting data. It was a process that had many layers to it, and it allowed me to really undertake my analysis in an iterative way, mapping key themes that were emerging and analysing the content of interviews and my interactions with informants. And it also allowed for triangulation between the different data sources. So when I got to my field site, I first piloted the interview guide and the focus group discussion guides with women who shared characteristics with the informants that I was seeking to recruit to participate in the research. And I also began attending breastfeeding educational workshops, and I continued to do this more or less every other month during fieldwork. And then I conducted my focus group discussions, and first that was with health workers and then with the breastfeeding counsellors. And this really helped to attune me to the key issues that were circulating in the lives of new mothers, and also local understandings of family planning and breastfeeding. Following the focus group discussions, I began interviewing my core or key informant group, and that was the women who'd recently given birth. Then after each interview, I would take field notes, and I'd also write up the key ideas and themes that had emerged after each interview in a summary form. And then at the halfway point, after having interviewed 10 women, I began to map the key themes that were emerging and refine the data collection tools. So I'd initially set out to explore breastfeeding and family planning, but the questions I had pertaining to more normative gender roles in families and how women were juggling their productive and reproductive work actually became integrated after those initial interviews. And so then I continued with the second phase of interviewing, and that included with some of the women I'd interviewed during the first phase, second interviews with those women. And then these interviews were followed by semi-structured interviews with informants whose agendas intersect with those core themes of family planning and breastfeeding, including to government officials who are responsible for devising and overseeing the implementation of health programs, a midwife educator from an Islamic university, and 2 volunteers from an NGO focused on male parenting. And over the course of fieldwork, I was, of course, keeping track of relevant legislation and local policies that were intersecting with these core themes. And so theme mapping and content analysis and the triangulation between data sources was just constant throughout this whole process. So what is this RED framework that I'm talking about? Well, it has 3 intersecting and dynamic levels, and it's a holistic and pragmatic way of understanding what's underpinning and influencing women's reproductive experiences and decisions at a specific point in time. At the outer level, we have formal reproductive politics, and by this I mean official health promotion agreements, programs, legislation and policy, globally and nationally. So this is what a lot of the time is informing policy and programming and interventions at the local level. It's in response to this formal political agenda. And at the middle levels, it's societal norms, and that's in reference to the constantly evolving and shifting ideals and expectations at the societal level about what's normative and what's acceptable and what women's and families should be striving for. And then at the inner level is women's intimate lives, and that's really concerned with women's day-to-day negotiations with their intimate partners, their husbands or boyfriends, their family members, their friends, their neighbours, health workers, employers or educational institutions, and whoever else is part of that inner circle and is influencing women's decision-making. So decisions about reproductive health are rarely autonomous in the Indonesian context. I don't know anywhere in the world where they would be autonomous. They're never really made in isolation of these other relationships. They're always part of the consideration. So the RED framework is really suited to understanding women's reproductive health in the Indonesian context because women's reproductive decisions and experiences are quite complex, they're multifaceted, and as is the case for women globally, reproductive lives are messy and non-linear. Women's reproductive health is shaped by these 3 levels simultaneously, and the RED framework really emphasises that multiple levels are influencing and constraining and supporting women to exercise their right to reproductive health and care. And the problem of focusing on just one of these levels in isolation from the others is that we overlook the reality of what shapes women's health. And from the RED, we can begin to gain a more complete picture. The RED framework can also help us to understand why a certain policy or legislation isn't working at the grassroots level, or why a community might be rejecting a new intervention. And this framework can help in the design of interventions that are more suited to the needs of the community in question. So now in this next slide, I've demonstrated how I applied the RED framework to one of the key things from my research on postpartum family planning in Yogyakarta. So at the outer level of reproductive politics, globally, we have these perpetual cycles of agreements and targets from the International Conference on Population and Development, the Programme of Action from that meeting, to the Millennium Development Goals, and now the Sustainable Development Goals. And we also have the global promotion of quality of care as part of that as well. And in terms of the methods of family planning that are being promoted globally and nationally, the emphasis is really on biomedical methods, specifically long-acting reversible contraceptives and contraceptive pills. Nationally, in Indonesia, we've also seen a persistently high rate of maternal death, government decentralisation and the privatisation of family planning, the lack of comprehensive sexuality education, and the ongoing promotion of small families. The slogan of the National Family Planning Program was perceived by some of my informants to have been diluted in recent times from the original Dua Anak Cukup, or 2 children is enough, to Dua Anak Lebih Baik, or 2 children is better. But the key message remains to contain family size. And at the societal level in urban Yogyakarta, private family planning providers really dominating the sector. And the long promoted small family norm has really stuck. Most people are satisfied with 2 or 3 children, provided they have one of each sex. And among my participants, their marriages were more companionate partnerships in terms of gender equality. And we're also seeing technologies, specifically social media and other digital technologies, influence the way that people are accessing information about family planning and seeking that information out. In women's intimate lives, we can see that women's reproductive health is being promoted through more choice in terms of family planning provider. Women in my study who were using non-biomedical methods felt empowered, and these women really understood that they have the right to choice in terms of family planning. And there were several constraints for the women in my study. Many only had partial knowledge of family planning, and quality of care among family planning providers was quite lacking in some cases. And there was also the circulation of myths about family planning methods and stories of others' positive or negative experiences. And these were really influencing quite strongly women's decision making. And many women were also relying on mass media and those online information sources, including social media. So these myths, stories, and online sources of information and support can really empower and support women in making decisions about family planning, but they're not really a substitute for comprehensive family planning counselling with a trained health worker. So I'll discuss a little more about the implications of the framework for practitioners in the field of reproductive health, but I also want to share how the process of developing this framework really helped to distill my findings around social stratification and the diverse middle class subjectivities among my informants. I was actually really quite tentative to place my informants into categories or subgroups of socioeconomic class. And this was partly because in piloting my interview tools, I was informed that I needed to be really sensitive in asking my informants about their household incomes, that it was too direct a question in Javanese culture, and particularly to ask it of somebody you just met for the first time. And incomes alone, I suppose, are a really subjective way of grouping informants together and categorizing them. And then I guess through the interviews themselves and in meeting these women at their homes or their workplaces, it really gave me greater insights into diversity of the middle classes rather than a middle class. But you know, that within the middle classes, there are distinct groups in there too. And the RED, in developing this RED framework, it really helped me to reconcile and visualise the interplay between the different levels within the framework and separate what most of my key informants shared, for example, their limited understandings of family planning, and this was in part due to the lacking quality of care that they were receiving when they were engaging in reproductive health services, but also due to the fact that mainstream reproductive, sexual and reproductive health programs are typically couched in terms of maternal health or postpartum family planning. and they're not really filling gaps in information that are, in the absence of a reproductive and sexual health education within the national curriculum before people get married and before they start even thinking about having children. Well, what set the core informants apart was that the range of choices that they had in terms of accessing family planning services differed. So women who came from more affluent backgrounds and who weren't reliant on public health services were able to actually take their time to choose their preferred contraceptive method, be it a modern method or a natural method. Whereas the women who had no choice but to engage with the public or government health services, there was greater coercion to begin using family planning during the postpartum period, sometimes immediately after childbirth. And there was also no choice for them to opt for a user-controlled or a natural method. So that's just one example of how the RED helped me to reconcile with the challenge that I encountered in seeking to understand the diverse choices that my informants made in relation to family planning and the extent that this was shaped by one's socioeconomic positioning. So what are the implications of this framework for the field? Well, reproductive health interventions are more relevant to the target population when their design is grounded in that group's experiences and decisions. And the beauty, I think, of this framework is its versatility in that it can be applied to other reproductive health issues, and it can assist policymakers or health professionals, program implementers, women's health advocates or other researchers to understand how women's reproductive health is shaped by these three intersecting levels of influence. And the RED framework really emphasises the need for these levels to be taken into consideration simultaneously when we're designing, implementing and evaluating reproductive health policies, programs and interventions. Well, thanks for watching my presentation. And in closing, I just want to acknowledge the broad-reaching support I've had in developing this work. Thank you so much.